We're at the 2018 CROI, and we're here with Ravi Jhaveri, who is the Associate Professor of Pediatrics at UNC Medical Center. And we very much appreciate you taking the time to talk with us about hepatitis C. And we don't, sometimes there's a lot of things we don't think about much.
Yeah.
But the subject that you're bringing up is really important to our audience and for preventative concerns.
Absolutely.
So hepatitis C in childbearing women, it's a big concern.
Yeah. So this issue has really come to the forefront in the last 10 years, and it's because we've seen this explosion of cases in young adults. And so obviously young adults includes women of childbearing age. They deliver infants, 3 million infants or so each year in the United States. And we've been seeing a steady increase in the number of HCV-exposed infants each year. And so with that comes issues related to testing, also screening during pregnancy and what we do. We don't have the kind of interventions that are in place for something like HIV yet, but the direct-acting antivirals offer that potential at some point. The challenge really is that we can't yet predict which women are going to transmit, and thankfully the transmission rate is still on the low side. So
it's maybe lower than HIV?
So it is. So let's say untreated HIV, you think somewhere around 20%, and obviously with the interventions we have in place now, it's less than 1%. With Hep C, the transmission rate is somewhere between 5 and maybe 15% at the upper limit, but really only about 3 to 5% go on to chronic infection. So until we can really narrow down.
But if you find a woman who is now, you said while during their pregnancy,
That's right.
You'd identify that. If you find out a woman is infected, and then there's still that chance. So do you treat then?
So right now none of the regimens are approved for use during pregnancy. Again, many of us hope that we get there soon. There are some preclinical studies, at least one that's looking at the activity and dosing of the drugs during pregnancy. But if you look at the safety profile of these drugs compared to many other, whether it's HIV antivirals or other antivirals, they have a very similar safety profile. The regimens now are so short that they could fit very nicely into the second trimester of pregnancy. You would achieve cure for the woman for herself. You would eliminate essentially any risk of transmission to the infant. You would eliminate any need to do any follow-up testing for the babies after delivery, and you could really simplify doing this. We also know that pregnancy is really a window of opportunity. Women consistently come to care. They have access to care because they are often covered through public insurance programs, whether it's CHIP-type programs or others. And so it's really an opportunity that we could take advantage of. We have not yet done that, but really with that comes many things. We would really need to expand our screening in pregnant women. Currently, we still only use risk-based screening, and many of us are advocating that we really need to screen universally because the prevalence now is so high in many parts of the country that it really makes sense and is cost-effective to do so.
So you might say that any woman who is anticipating becoming pregnant or having babies, it would be sensible to do this testing before they even think about that.
Absolutely, and potentially even get treated ahead of at least at the current day, get tested, identify your status, and if you happen to be infected, go ahead and get treatment taken care of, because essentially not only do you cure yourself, but you eliminate any risk of transmission in the future.
Now, do you know the interval of transmission? Is it at the point of delivery, or is it? So
unlike HIV, let's say, we know from past studies with Hep C that C-section doesn't make a difference, viral loads doesn't make a specific difference, that a woman can transmit regardless of the mode of delivery and regardless of her viral load. So this, in my mind, argues that this is likely an in utero transmission event, and we have yet to figure out if it's something specific to a person's genetics, if there's something specific about the viral genetics. Those factors haven't yet been determined. But we think that this happens before delivery, and so, but we don't know when.
Because now, if a child is, or an infant is born infected, the small percentage that there is, but there is that. I mean, there are
That's
obviously
right.
kids now.
That's
What
right.
do they do?
Well, so thankfully, many of those infected infants really have no symptoms for years. And so I've had many patients in my practice that, let's say, didn't present until they were teenagers. They went to donate blood at a high school blood drive, and their screening test showed positive for Hep C. And then they're sent a letter and they come to see me. So you can go for 10 or even 20 years or more without any symptoms whatsoever.
Just be watched and so
Just be
forth.
watched, but the challenge is that we know that teenage years end up being a time when high-risk behaviors start to manifest, and so you wouldn't want someone who was infected and didn't know it to go out there and perhaps experiment with IV drugs and perhaps high-risk sexual practices. So if you could identify and eliminate them, their infection sooner, it would really be to our advantage from a public health standpoint.
Well, these are really important points you make, and I think it's something that I don't think many people think about, but they should.
Agreed, and I think that one of my goals is to really sort of talk about the burden in children, pregnant women, the infants they deliver. It's an important part of trying to tackle the entire societal problem of Hep C.
Apart from the fact that you're looking at how to make this all happen better, like you said, this is where we are now. What would the improvement, or are you working on anything that's going to make maybe a difference in the near future, how we approach this?
I think, again, trying to get the awareness out there, and certainly thankfully the directly acting antiviral regimens are slowly making their way into pediatrics. We have one approved regimen now for kids down to 12, so trying to get that out to as many kids that are infected as possible. We're part of the industry-sponsored studies that are looking at several of the other regimens that will increase our options, and potentially those will get down to kids as young as 3 years old. We wouldn't treat kids before that because there's still a chance that before 3 that a child could resolve their infection. And so really after 3, you're looking at potential treatment options. And again, the sooner we can identify them and perhaps get them treated, the quicker we can resolve their infection and save
their
them
health
the
status
potential
would be,
future benefits.
So now they're advertising the treatments for people who are, yuppies and all certain ages. And well, I think now we need to think more in terms of everyone should be tested.
That's right. I think if you look at the current statistics, and one of my projects has really looked at state-by-state data, and now if you look at the prevalence in young adults, in many states it's as high, if not higher, than in the baby boomer population we classically associated with Hep C. So I think a lot of our old or prior notions about Hep C we really sort of need to move on from, and really just think about society overall being at risk and young adults overall being at risk, and then all of the populations like exposed infants that come from those cases.
Because people of the early years that have been dealing with this as a real traumatic experience getting treated. It isn't that anymore.
That's right.
It's not innocuous, but it's definitely not anywhere close to the health drama that you had in the old days. So, so this is important. Absolutely,
and certainly for those of us that are involved with kids, I think that young kids present us with an opportunity before they get to the teenage years. They tend to be fairly compliant. They haven't yet entered a rebellious phase. Most of them can take oral medications and pills without a problem or with a little bit of coaching. And they don't have the comorbidities like diabetes or other things that you really have to worry about when you're thinking about Hep C plus their treatment. And so it makes it pretty straightforward. And again, the studies that have been done have really showed that the kids respond at an even higher rate than adults do.
This is great information. I really appreciate you taking the time with us, and always come back when the situation changes and we need to update people on how we're looking at it now.
Thanks for having me. I really appreciate it.
Thank you.
Thanks.